Hit the subscribe button or visit us at auau.auanet.org.
Good evening and welcome to the AUA's What's New in the Management of Hormone Naive and Castrate-Resistant Prostate Cancer, a case-based session for urologists, advanced practice providers, and teams. Thank you so much for joining us today. Before we get started, we'll go over a few items so you know how to participate in today's event. All attendees are in listen-only mode, but if you have questions, please feel free to send them to us through the questions pane. The AUA is accredited by the ACCME and designates this internet live activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from this presentation have been made available to you, so please visit AUA University to access these handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the webinar. As the AUA continues to develop virtual education that meets your needs, we welcome your feedback regarding both the content and the format of this webinar. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit the AUA University to view Faculty and Education Council disclosures. Coding advice given during these presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. We hope that you will actively participate as you connect and learn from each other during this course. Due to the size of the audience, all participants will remain in listen-only mode without video. However, we definitely encourage you to ask questions at any time. You can submit these questions in the questions pane on your control panel. We also encourage you to get social online and share highlights from this virtual experience with the global urology community. When you do, please tag the AUA at Amer Urological and use the hashtag AUA Virtual EXP, and for summer school specifically, AUA Summer Ed. Please stay tuned for a keyword that we will provide during the webinar. The keyword is used to verify your participation in the webinar. You will need the keyword to access the course evaluation, CME credit claim, and certificate. The AUA would like to thank the following companies for providing independent education grants to support this webinar: Astellas, AstraZeneca, Bristol Myers Squibb, Genentech, Merck, Pfizer, Sanofi Genzyme. Finally, I'd like to extend a special thank you to our course director, Dr. Judd Mell, for his time, talent, and expertise in developing this program. Before we begin the webinar, we will take a few minutes to conduct a knowledge assessment. I will turn this over to you, Dr. Mell.
Thank you very much. It's a real pleasure and honor to be here, and we obviously wish we were able to attend the AUA this year in person, and let's pray for next year, but we're so grateful to the AUA for putting on this summer school. I understand that these courses have been going on most of the summer, and we're excited to present this one on advanced prostate cancer, and I promise that we will try to make this as educational and as possible, giving everyone some of the key teaching points. Let's get right into the questions so that you'll have a better understanding of what we're going to be dealing with this evening. So here's question number one. According to the 2020 AUA guidelines for advanced prostate cancer, which of the following statements is not true regarding treatment options for men with newly diagnosed metastatic hormone-sensitive prostate cancer? A, in addition to androgen deprivation therapy, treatment intensification should be considered with enzalutamide, apalutamide, docetaxel, or abiraterone prednisone. B, 6 cycles of docetaxel in AD should be considered in high or low volume de novo disease based on the interim and final analysis of the chartered clinical trial. C, androgen deprivation therapy and first-generation anti-androgens, bicalutamide, flutamide, or nalutamide, are no longer considered the standard of care for this disease state. And D, androgen deprivation therapy and abiraterone prednisone demonstrated significant improvement in overall survival and progression-free survival in the interim analysis as well as the final analysis of the Latitude clinical trial. So which one of those statements is not true? And here's your quick poll. This is going to be from Dr. Karsh's talk. So for those who may not be completely sure of the answer, don't worry, Dr. Karsh is going to go over this. This is one of his learning objectives for this question number 1. And we can move on to the next.
Well, we're going to give it just a few minutes, a few
Sure.
moments more to get, if we can get just a few more.
For the residents who were attending, and I know there are a number of residents from multiple programs, these are really good questions to practice for the in-service exam. Obviously, these are not the identical questions. We would not be able to do that, but these are the type of questions that you would expect to see on the urology in-service exam on this topic. Okay, let's go to question number 2. A 71-year-old pediatric surgeon who retired to a home in the mountains fell off a ladder and fractured his wrist and ankle. Let's go. Oh, we seem to have gone. And fractured his wrist and ankle. He was not intoxicated, but admits to about 4 ounces of alcohol per day. He never had a seizure. He has moderate voiding dysfunction. Imaging demonstrates 3 osteoblastic lesions at T7, L2, and L5. PSA was 113. A CAT scan was negative for visceral or soft tissue disease. T7 bone biopsy was positive for metastatic prostate cancer. Liver enzymes are slightly elevated, but the bilirubin is normal. Germline testing is positive for BRCA1. You diagnose low volume, metastatic hormone-sensitive prostate cancer. In addition to androgen deprivation therapy, you would treat him with A, enzalutamide or apalutamide, B, abiraterone, prednisone, and prostate radiation therapy, C, 6 cycles of docetaxel, or D, olaparib or rucaparib. And so let's go right to this. And again, this is taken from Dr. Karsh's talk, which is going to be upcoming next. Please answer which you believe would be the most appropriate treatment for this patient.
All right, it looks like we're about %, so we'll just give it a few more seconds.
Yeah, I want to just compliment Dr. Karsh. This is a really good question and not necessarily not an easy question necessarily. So this is a good knowledge test. Very good. Okay, so let's go to question number 3. A fit 68-year-old male with bone metastatic castrate-resistant prostate cancer received abiraterone acetate, and he progressed by PSA after 8 months. He then receives docetaxel 6 cycles with a transient response in pain symptoms and PSA before both the PSA begins to rise again and his pain symptoms recur. His restaging bone and CT scan reveal no visceral lesions, but multiple new bone metastasis and multiple 3 to 5 centimeter enlarged pelvic and retroperitoneal lymph nodes. What is the best treatment of choice for this patient? Is it A, enzalutamide, B, radium-223, C, sipuleucel T, or D, cabazitaxel? And here's our answers. And this excellent question comes from Dr. Yu. And so this will be covered on our 3rd talk on Dr. Evan Yu is going to be covering metastatic castrate-resistant prostate cancer. So please give us your best choice for this particular patient.
All right, next question.
Question number 4. A 53-year-old male with metastatic castrate-resistant prostate cancer has previously received abiraterone acetate, docetaxel, radium-223, and cabazitaxel. His disease is progressing, and his most recent staging imaging reveals multiple new 1 to 3 centimeter liver metastases. His ECOG performance status is 1, and he tells you he would like to try more therapy. You perform a metastatic biopsy of a liver metastasis, and you find an MSH2 alteration with accompanying microsatellite instability. This opens the door for which of the following treatment options: A, sipuleucel T, B, atezolizumab, C, pembrolizumab, and D, olaparib. So answer your best question. And again, we have to also thank Dr. Yu for the excellent question and putting us right in the state of the art of some of the newer options for advanced prostate cancer. Hopefully you'll remember these questions, and then you can focus on the answers as my 2 esteemed faculty members give their talks. And then the final question, question number 5, maybe a little bit easier. This is on M0 CRPC, is defined by which true criteria? A, PET scan with no detectable metastatic disease. B, serum testosterone level less than 20 while on continuous androgen deprivation therapy. C, rising PSA while on continuous androgen deprivation therapy. Or D, nodal disease outside the true pelvis. So which one of those is the true or a accepted definition of M0 CRPC?
All right, we'll give it just a few more moments. Looks like we have about 60%. All right, that concludes our knowledge assessment. Thank you for participating, and we will now get started with the webinar.
So it gives me a great pleasure to be part of this course, and I'm delighted to have 2 friends and colleagues, Dr. Larry Karsh and Dr. Evan Yu. Dr. Karsh is a urologist in Denver, Colorado, the Urology Center of Colorado in Denver, and he's part of a large urology group practice association, and that organization has really had a big impact on advanced prostate cancer. A cadre of outstanding urologists have taken on advanced prostate cancer, and Larry is one of the leading authorities on advanced prostate cancer as a urologist, does a lot of clinical trials, and I've been fortunate to work with Larry over the last number of years on this course. Dr. Yu is a medical oncologist professor at the University of Washington in Seattle, noted authority on advanced prostate cancer, and we're so delighted that he was able to join us at the, we were all supposed to be in person at the AUA back in May, but we're so delighted that he was able to continue his involvement with us and be part of this summer school. And so we're going to now turn the podium, if you will, over to Dr. Karsh. For the sake of time, I will not read the learning objectives. Suffice it to say, I think you all got the learning objectives in those 5 questions. So we'll turn it right over to Dr. Karsh.
Thank you, Judd, for that nice introduction. Good late afternoon or early evening, depending on which coast you are on. I'm glad to be joined here again with you, Judd, and Evan, my esteemed colleagues and good friends. And what I'm going to do is talk to you about tailoring the treatment for metastatic hormone-sensitive prostate cancer. And let me see if I can get this next slide. Can you move that next slide for me? There. These are my disclosures. Next slide, please. So this is, ADT has long been the gold standard treatment for men with metastatic hormone-sensitive prostate cancer. And it all began with this seminal paper by Dr. Charles Huggins. For almost 80 years, we did not have another therapy or combination therapies that had meaningful effects on overall survival. Now that changed in 2015 with this new era of treatment intensification using docetaxel, abiraterone, apalutamide, and enzalutamide, and that really revolutionized standard care over ADT alone. So this is going to be the focus of my discussion today. We'll go on to the next slide. So this slide depicts the continuum of prostate cancer progression. If you focus on the balloons on the top half of this slide and looking at metastatic HSPC, patients enter the continuum with either clinically localized disease after primary treatment with surgery or radiation, and they can progress to metastatic HSPC, or they present with de novo metastatic disease. They've never been diagnosed or treated for prostate cancer. And that's called de novo disease. And this is something I'm seeing more commonly in my practice today in my advanced therapeutics clinic. But irrespective of how they get to metastatic HSPC, progression on ADT leads directly to metastatic castration-resistant prostate cancer. And we'll go on to the next slide. So, are there differences between de novo metastatic prostate cancer and those patients who evolve after primary treatment or progressive disease? There actually is not a huge amount of data out there, and there's really an intrinsic belief that de novo disease represents a more aggressive biology, as opposed to the patient who might have had primary therapy some years ago and evolves to metastatic disease. So this was published in 2017, not a lot of high science here, and that's a small study, and it was a retrospective analysis, but at least it is some data that would suggest that in fact men with de novo disease do worse. Next slide. So these are the 2020 AUA guidelines for advanced prostate cancer. I think they're great guidelines. They're really a great improvement over the guidelines before, and I have to commend Mike Cookson for assembling a multidisciplinary group of urologists, medical oncologists, radiologists, and radiation oncologists. And the nice thing about this is it makes it easy to navigate. If you click on the discussion button, it gives you all the data that they use to get to that the guideline. Now, if you notice the terminology here, metastatic hormone-sensitive prostate cancer, and we go on to this next slide, and we see the NCCN guidelines, which are also, to be fair and balanced, are great guidelines as well. But if you look at the terminology, it says castration-naive prostate cancer. And there are a number of different terms to describe the same disease state. But these guidelines from the NCCN, the nice thing about it is they update frequently and make changes, but they're a little harder to navigate than the AUA guidelines. Let's go to the next slide. So the disease state has different terminologies. We have metastatic hormone-sensitive prostate cancer, metastatic castration-naive, hormone-naive, non-castrate prostate cancer, and metastatic castration-sensitive prostate cancer is the terminology used by the FDA and how they approved the therapies, which we'll talk about, enzalutamide and apalutamide. But regardless of what terminology you use, it indicates that these patients are hormone naive and they have metastatic disease. Next slide. And so this is guideline number 13. So in patients with metastatic HSPC, regardless of age and family history, clinicians should offer genetic counseling and germline testing. Next slide. This is guideline 15, and this really lays the groundwork for demonstrating that ADT alone is no longer the standard of care for patients with MHSPC. And we use the combination of either abiraterone, apalutamide, enzalutamide, or chemotherapy, docetaxel. And this has a strong grade A level of evidence, which is the highest grade that the AUA gives to these guidelines. Next slide. So these are the approved agents. It's not very difficult. There are 4 choices that you have. Docetaxel was approved based on the CHARTED and STAMPEDE trials. Abiraterone was approved on LATITUDE and STAMPEDE. Enzalutamide was approved based on the ARCHES trial, and apalutamide was approved based on the TITAN trial. Next slide. So these, let's review the characteristics of enrolled patients into the CHARTED study as well as LATITUDE and STAMPEDE studies. So in CHARTED, we have a volume or burden of disease definition, and you can see in the definition in terms of visceral mets, 4 or more bone lesions with 1 outside of the axial skeleton. And the alternative, of course, was low volume. So in CHARTED, only the high volume group derived a significant overall survival advantage with 6 cycles of docetaxel. Now, there were 2 trials that evaluated abiraterone. They are the STAMPEDE trial and LATITUDE. In LATITUDE, it was different than a volume definition in CHARTED. They combined a pathologic definition with a volume definition to come up with a risk definition. So you have to have at least 2 of the following Gleason score 8 or greater, 3 or more bone lesions, and measurable visceral mets. And it's really similar to the high volume group of CHARTED. And in STAMPEDE, different. Newly diagnosed metastatic node positive or high risk localized advanced disease with at least 2 of the 3 T3, 4, Gleason score of 8 to 10, and PSA of greater than 40. So STAMPEDE included patients with locally advanced or node positive disease, where CHARTED and LATITUDE did not. And when we look at the definitions in the guidelines, they're really looking at the volume definitions for high or low volume disease. Next slide. So really focusing on intensified upfront therapy for prostate cancer, we really have to ask ourselves, is earlier better? And I'll show you data to support that hitting the prostate cancer early is critical to long-term control. Next slide. So this is where the revolution began in 2015, where we have this new intensification era. So that in CHARTED, we use docetaxel. Now, docetaxel was approved off to the right in the metastatic castration-resistant prostate cancer patients based on the SWOG 9916 and TAX 327 trials. And there was about a 2-month survival advantage. You know, back then in 2004, urologists were getting too excited about it. We were having patients living much longer on ADT alone. But now with the CHARTED trial looking at upfront docetaxel with ADT, so we've increased the survival. When you look at the high and low volume, was 13.6 months. But if you dissect out the high volume, it's about 17 months. And this was confirmed simultaneously by STAMPEDE. Next slide. And hitting it hard early is critical to long-term control. Next slide. So this was the CHARTED trial. All these trials are similarly designed. We had ADT plus docetaxel, 6 cycles of docetaxel, or ADT alone. This was stratified by high or low volume, and the primary endpoint was overall survival. Next slide. And when you looked at the high and low volume, there was a benefit of overall survival in the high volume, and this is in the final analysis. but it never really panned out in low volume. So that it really is only effective in high volume disease. Next slide. Now, when they looked at the low volume, they tried to dissect out, well, was it better in de novo disease or progressive disease? But there was really no difference. So there's no survival advantage in the low volume group in the charted trial. Next slide. So in Stampede, similar findings. We had similar survival with docetaxel as we did in the charted trial. Next slide. So this revolution continues with abiraterone. Remember back, abiraterone was first approved in the Cougar 301 and 302 trials for pre and post docetaxel in metastatic castration-resistant prostate cancer. And there was an overall survival advantage by about 4 months in each of those trials. And now looking at upfront abiraterone, we see a significant survival advantage using it upfront with ADT. And next slide. So this was the clinical trial. Remember, these were all patients with de novo presentation. And it really answers the same question that Charted did, but it's looking at abiraterone instead of docetaxel. And so this, you really could argue this was the highest risk population because they were all de novo patients. 1,199 patients were randomized 1-to-1 to get ADT and ABI and prednisone versus ADT and placebo. The co-primary endpoints were overall survival and radiographic progression-free survival, which it met its endpoints. Next slide. So in the final analysis that was presented at ASCO GU in 2019, you can see that the updated results were presented, and it's not that it's surprising because these were the same findings we saw in the interim analysis, but these data are compelling and remain important. There was about a 16.8 month survival advantage with abiraterone. Next slide. And Stampede, multi-arm, multi-stage trial. This is really a great overall study by the Brits. They have all these different arms and stages, and it's the gift that keeps giving. But they also looked at abiraterone, similar to the Latitude trial, and they found that the results were actually a mirror image of what was demonstrated in the Latitude trial. The hazard ratio was almost the same, 0.63. So there was a survival advantage with abiraterone in that trial. Next slide. So the revolution continues with Enzamet. So it's enzalutamide with ADT. And we recall back that enzalutamide was first approved in metastatic castration-resistant prostate cancer, both pre and post docetaxel in the Affirm and Prevail trial. They had overall survival advantage by about 4 and 5 months. And then enzalutamide was also approved for delaying metastases in non-metastatic CRPC in the Prosper trial. And that was approved in 2018, and Dr. Mall is going to talk about that. Now, it also improved survival in the Enzamet trial. Now, the Enzamet trial was not the trial that got the approval for enzalutamide in the US. It was the Arches trial. But the reason I show this is because there were some important points about Enzamet. And one is that they had their primary endpoint was overall survival, and it reached that. Next slide. But there were some interesting things about this trial. Now, they had an active comparator that was that the investigator could choose this non-steroidal anti-androgen, bicalutamide, nilutamide, or flutamide. They had high and low volume stratification as well as anti-resorptive stratification. And the primary endpoint was overall survival, which it did meet. Next slide. But they broke this up into some subgroups. Now, it's important to remember that the efficacy and safety of enzalutamide in combination with docetaxel in this trial was not established because Enzamet was neither designed or powered to analyze the results of overall survival in individual groups. But that being said, there was significant PFS, whether, if we look at this group of whether or not these patients had docetaxel. So it's kind of like triple therapy, docetaxel, enzalutamide, ADT. But if they had docetaxel, what we found in this subgroup was that there was no survival advantage in using enzalutamide over the active comparator arm. Whereas with no docetaxel, you see a survival advantage. But again, the caveat is that it wasn't powered for this, but it's interesting because now that we have this new era of intensification, is more better? Maybe not, but I think we're going to have clinical trials to determine that. Next slide. So these are the new treatment options, the newest to the armamentarium in 2019. We have apalutamide and enzalutamide. These are both third-generation androgen signaling inhibitors. They work at multiple steps along the androgen signaling pathway. Apalutamide is touted as less likely to cross the blood-brain barrier, but they both do it. Apalutamide was first approved in the Spartan trial for non-metastatic castration-resistant prostate cancer, and it was approved in 2019 for metastatic hormone-sensitive prostate cancer. Enzalutamide has been approved across the entire spectrum. Metastatic castration-resistant prostate cancer. In the non-metastatic CRPC, the PROSPER trial got the approval, and now through the ARCHES trial. Next slide. So this is the ARCHES trial, and again, it addresses a similar question as the other major studies like Latitude and Charted, but it substitutes enzalutamide. But the one primary difference between this and the other trials is that the primary endpoint was rPFS, radiographic progression-free survival. It did hit that endpoint, and overall survival is a secondary endpoint, and that data is not mature yet. But these patients were stratified between high and low volume disease and whether or not they had prior docetaxel. So next slide. So this is the rPFS curve from the data presented at GU ASCO in 2019. Again, biologically and clinically very compelling for at least the endpoint of radiographic progression-free survival. The hazard ratio was 0.39 with a very highly statistically significant p-value. And remember, this is the trial that got the approval for enzalutamide in intensification treatment. Next slide. So irrespective of whether it was high or low volume disease or whether patients had docetaxel or not, there was advantage in using enzalutamide and ADT over placebo and ADT. Next slide. And this was the Titan trial. This got the approval for apalutamide. Similar design, answering the same question. Apalutamide and ADT versus placebo and ADT. There were dual primary endpoints, overall survival and rPFS. And it was stratified high and low volume and use of docetaxel or no docetaxel. Next slide. So you can see that the overall survival met its endpoint. The hazard ratio was statistically significant, 0.67, with a 33% reduction in the risk of death. And on the next slide, you'll see that rPFS, next slide, also hit statistical significance with a hazard ratio of 0.48 and a 52% reduction in the risk of radiographic progression or death. Next slide. So how do we choose between these upfront agents? We have 4 to choose from. Docetaxel is a chemotherapy. The advantage is that it's short-term, 4.5 months. But because of side effects, patients may miss some time off of work. There are toxicities like peripheral neuropathy, pancytopenia, hair loss. It requires corticosteroids. It is only effective in high-volume patients. If you look at abiraterone, it's an oral. It's now generic. You use it for a longer term, but it's still, even though it's generic, it's not free and it's still expensive. And we have to look at the toxicities of abiraterone, check for liver enzyme function, electrolytes, hypertension, the mineralocorticoid effects, and steroids are required, but you can use it in high and low volume disease. Same thing with enzalutamide and apalutamide. There are prescription co-pays. It's a longer term treatment. They do cross the blood-brain barrier. The patients with seizures were not allowed in the study. There were still some patients with seizures that, in the study, and because it crossed the blood-brain barrier, there can be some cognitive function dysfunction and falls. Steroids are not necessary, and they're for high and low volume patients. Next slide. So why not mix these all together? I think I talked about this in a previous slide looking at Enzamet. You know, if two treatments are good, why not three? But I think we saw in the Enzamet trial that there was less benefit seen in patients, in the high volume patients, who you would expect to respond to docetaxel. But in that cohort of patients, we found that docetaxel addition was not more effective. And we need dedicated trials that will answer these questions. Arisens is a trial looking at docetaxel and ADT plus or minus darolutamide. The PEACE trial is looking at ADT and docetaxel plus or minus abiraterone. And so I think that we're going to have to wait and see what the results are of these trials to know whether or not we should be using triple therapy up front. Next slide. And this was the Arisens trial. There are 1,300 patients. They've already all been enrolled. The study is ongoing, and the completion is estimated at August of 2022. I think it may be earlier than that, but I could be wrong. Primary endpoint is overall survival, and you can see these other secondary endpoints. Next slide. And my last, I'm going to close with my last guideline 16. In selected patients with MHSPC that have low volume metastatic disease, clinicians may offer primary radiotherapy to the prostate in combination with ADT. Now, this was a lower grade evidence, grade C, but it's based on this next slide, which I want you to put up, and it's from the Stampede trial, which showed, if you look at the top line there, overall survival in the low metastatic burden patients was improved with the use of radiotherapy to the primary, whereas in the high volume disease, there was really no difference. So there is some evidence out there to suggest that if you have oligometastatic disease, that you should consider radiotherapy to the primary and sometimes to the metastatic site. If it's a painful site or if it's in an area that's weight bearing, you may want to consider radiating those sites as well. But again, low metastatic burden. Next slide. So in conclusion, and these are some take-home messages, ADT monotherapy is no longer the standard of care. It is combined therapy with either docetaxel, apalutamide, or enzalutamide. Docetaxel is only for high volume disease, whereas the other three can be used in high or low volume disease. Triple therapy with docetaxel needs further study. There are other combinations that are underway, even looking in this disease state at enzalutamide plus or minus pembrolizumab, which is a checkpoint inhibitor, or abiraterone with or without niraparib, which is a PARP inhibitor in marker-negative patients. But in any event, we go on to consider primary radiation to the prostate, which I just mentioned in oligometastatic disease. Genetic testing is recommended for all patients with metastatic prostate cancer. And as a clinical trialist for over 20 years, clinical trials are near and dear to my heart, and clinical trials should always be considered in cancer patients. Next slide. So thank you very much from the Mile High City of Denver. We'll welcome some questions later, and I'm going to hand the program over to Judd. Thank you.
Thank you very much, Larry. That was a fantastic talk, and you. So all the attendees tonight you definitely should get those first 2 questions right on your retest later based on Dr. Karsh's excellent talk. Let's go directly into my presentation. And so over the next, hopefully less than 15 minutes, I'm going to try to give you a very focused overview of non-metastatic castrate-resistant prostate cancer. Now, let's go backwards a little bit. Dr. Karsh just gave a great talk on metastatic hormone sensitive. Now I want you to forget about metastatic, at least as far as a positive bone scan or a CT. These patients had already been put on hormone therapy, but never had metastasis. So these are men right off the bat who are negative as far as their scan results. I bring greetings from Duke University and the Duke Cancer Institute here in Durham, North Carolina. These are my disclosures. And I want to go directly into a case just to set the tone. So we have a 73-year-old retired grocery chain executive. Of course, I'm in North Carolina. You could probably guess what chain that is, but don't want to violate any HIPAA here, but this is a real case. 73-year-old retired grocery chain executive, robust overall health. He presented 5 years ago with moderate volume, Gleason 4+3=7, and a PSA of 13. So he was a solid intermediate risk or unfavorable intermediate risk from the get-go. He went through our Duke multidisciplinary clinic, which includes a urologist, radiation oncologist, and medical oncologist. And after full counseling, he elected radical prostatectomy. Postoperatively, he was pathologic stage T3B and actually was upgraded to Gleason 9. So had definitely adverse features after radical prostatectomy. He received adjuvant radiation therapy plus 6 months of androgen deprivation therapy after he regained his continence. And then his PSA unfortunately began to rise about 3 years ago. And at a PSA of 5, he restarted androgen deprivation therapy. His PSA declined to about 0.5 point about 7 months after restarting ADT. But his PSA has currently risen to about 2.8. He has a castrate serum testosterone level of less than 50. His PSA doubling time is 9.5 months, and his restaging bone scan and CAT scan of the abdomen and pelvis are negative for metastasis. So if you don't remember anything else about this talk, this is a gentleman who's squarely with all the criteria for non-metastatic or M0 CRPC, and what are the options? So let me just play devil's advocate for a moment. I suppose there are urologists who may say the following: hey, the guy's feeling well, why introduce any possible side effects? Fatigue, he's asymptomatic, just let it go. The novel hormonal therapy agents that Dr. Karsh just talked about, and I'm going to be mentioning in a few minutes, they're pretty expensive, and it's really difficult for my office to deal with those new drugs. So we're just going to we're not going to bother. I'm not sure that metastasis-free survival is a valid endpoint. Remember, they were originally approved for metastasis-free survival. Or you could say, well, I'm just going to get a PET scan and try to prove that he has metastatic disease and then use docetaxel. Well, Dr. Karsh just mentioned that, okay, even if you get a PET scan, remember his bone scan and his CT were negative, so it's unlikely that he has high volume metastatic disease, but you could do that. I'm going to use bicalutamide now and hold the big guns until he really needs them. Well, bicalutamide, you could do that, but that's kind of an old-fashioned, lower potency oral anti-androgen at this point. Or I'm going to just monitor him until his PSA doubling time gets worse. So it's like 10 months now, but let's just wait till it gets to 3 to 6 months and then deal with it. I'm going to just monitor him until he gets metastasis. Okay, I'm just going to monitor him, and then when he gets M1 disease, then we'll treat him appropriately, just like Dr. Karsh just discussed. I'm not convinced that these agents now are worth it, or probably the one that I'm most worried about, I'm not sure which agent to use since we have three good choices. And unfortunately, some people may get paralyzed, say, well, I can't decide, so I'm not going to use any. So Those are the devil's advocates. Now, let me try to convince you otherwise. First off, when we're dealing with non-metastatic CRPC, we want to make sure the patient has a castrate level of testosterone, and it's less than 50, not 20, it's less than 50. Even though 20 is nice, but it doesn't have to be, it's less than 50. You have to have no tumor seen on standard imaging, standard bone scans, standard CT. You don't need to do a PET scan. You have these FDA approved agents, you can do standard imaging, and if those are negative, you have the ability to use these agents. And you generally want to pick patients, though, who have a PSA doubling time less than 10 months, because those were the patients who were enrolled in the trials, even though technically the FDA, when they approve these drugs, they don't require the patient to have a PSA doubling time less than 10 months. M0 CRPC is PSA progression without metastasis and a castrate level less than 50. M1 disease is going to be radiographic visible disease on imaging or radiographic progression. And this cartoon basically just tries to put that in perspective. The guy with non-metastatic CRPC had been on someone put him on hormone therapy for a PSA recurrence. Someone maintained him on hormonal therapy for a PSA recurrence. Now he has a rising PSA, and he's in your practice with this rising PSA and negative metastatic disease. He fits the criteria of non-metastatic CRPC. What are we trying to achieve? Well, we're trying to prevent metastasis, and we're trying to prolong quality of life, or preserve quality of life, and we're prolonging survival. And that's now been proven based on ASCO 2020 presentations. There are 3 completed trials and 3 FDA approvals. The PROSPER trial resulted in approval of enzalutamide, the SPARTAN trial resulted in approval of apalutamide, and the ARAMIS trial resulted in the approval of darolutamide. You heard Dr. Karsh talk about enzalutamide and apalutamide. We're introducing a new drug here in this talk called darolutamide, but we have these 3 agents that are all now FDA approved for this state of disease. This is a busy slide. Let me just summarize it to say that PROSPER, SPARTAN, and ARAMIS were all very similarly designed. They all enrolled well over 1,000 patients. The randomization was 2-to-1 for each of the trials, meaning 2 patients for each 2 patients who received active drug, 1 patient received placebo. The stratification was all by a PSA doubling time, and enrollment required a PSA doubling time less than 10 months. They all had to have a baseline PSA greater than 2. So again, in your practice, if you're looking out for these guys, these are essentially patients in your practice who are on traditional androgen deprivation therapy, who now have a rising PSA above 2, although you can put them on a watch list before they reach 2, but above 2 for the trial. They all have to have had good performance status. Now, these drugs, at least enzalutamide and apalutamide, rarely can cause seizures. And so for both PROSPER and SPARTAN, patients who had a seizure disorder were excluded. For ARAMIS and darolutamide, because darolutamide does not generally cross the blood-brain barrier, it is felt to be a safer drug with regard to patients who may have a seizure disorder, and those patients were allowed to enroll. PROSPER did not allow patients who had significant cardiovascular disease to enroll, nor did ARAMIS. However, the SPARTAN trial with apalutamide did not have any form of exclusion based on cardiovascular toxicity or cardiovascular history, and their primary endpoint was all metastasis-free survival, but overall survival has been a secondary endpoint and now proven. The efficacy comparison is pretty similar. These drugs all met their primary endpoint. These drugs now all met their secondary endpoint. I'm going to talk about this a little bit later when the summary was given for ASCO, but they all resulted in a robust metastasis-free survival benefit of about 2 years. So again, if you place a patient on these drugs, you're actually going to get a metastasis-free survival benefit of average about 15 months, a little shy of 2 years, but again, anywhere from around 15, 16 to 18 months. The adverse events, I will say these drugs are all well tolerated, but as urologists prescribing these drugs, we definitely have to have an understanding of side effects and know what to look for. Fatigue is a fairly significant problem, or can be a problem in some patients, particularly with enzalutamide and apalutamide, slightly less or somewhat less with darolutamide. Again, enzalutamide and apalutamide do cross the blood-brain barrier, and that's felt to be at least one of the hypotheses on the fatigue. Darolutamide, not so much crossing the blood-brain barrier, a little less fatigue. You see hypertension, you see rash. Apalutamide is associated with a rash in about 20 to 25% of patients. Most of the time it's a mild rash. Rarely does it require steroids, but it's something that you need to be aware of and know how to manage that. Falls and fractures can occur in the Prosper trial and the Spartan trial with both enzalutamide and apalutamide, less so with darolutamide, again, presumably due to less crossing of the blood-brain barrier. And then adverse events leading to drug discontinuation across the board, under 10%, anywhere from 6 to 9%. And that was similar with all three drugs. Adverse events leading to death, again, a fairly low rate, as you can see on the bottom part of this slide. So I just want to then summarize at the ASCO 2020, which was held in June virtually, all three of these drugs reported out, or trials reported out, overall survival. So first off, with Spartan and apalutamide, the overall survival on the third analysis with a median follow-up of 52 months, median overall survival with apalutamide was 73.9 months versus 59.9 with placebo, hazard ratio 0.784, p-value 0.161, and it did meet the pre-specified target value for statistical significance, resulting in a 21.6 relative risk reduction of death from prostate cancer. That was presented by Dr. Eric Small at virtual ASCO in June. Prosper, again, similar findings presented at ASCO, 27% decrease in the risk of death. Median follow-up was just slightly less at 48 months. Overall survival duration, 67 months for the 933 patients who received enzalutamide, and 56.3 months among the 468 patients given placebo. Enzalutamide treated participants longer time to first use of subsequent anti-neoplastic therapy than their placebo-treated counterparts at a median follow-up of 66 versus 19 months. And that was presented by Cora Sternberg from Cornell at ASCO. And then finally, darolutamide, the Aramis trial, also presented at ASCO, 31% reduction in the risk of death. Median follow-up a little bit less at 29.1 months. However, 3-year overall survival rates were 83% versus 77% for darolutamide and placebo. And darolutamide was associated with significant delays in the time to pain progression, first cytotoxic chemotherapy, and first symptomatic skeletal event. And that was presented by Karim Fassizi from Paris, again at ASCO. Now, what's the bottom line summary? The discussant at ASCO was Tom Beer, who is a friend and wonderful medical oncologist at Knight Cancer Institute in Portland. And I just want to read his comments. it makes it clear that in castrate-resistant prostate cancer, early intensification of hormone therapy results in an overall survival advantage. So these 3 agents, when used earlier in non-metastatic castrate-resistant prostate cancer, resulted in an overall survival advantage. Then he added that meaningful differences in the efficacy between these 3 studies are not apparent. And although the median overall survival estimates and hazard ratios look a bit better in the trials with longer follow-up, none of these studies are fully mature for overall survival, and the estimates are likely to change with additional follow-up. So from an academic standpoint, I think that all 3 of these trials met their endpoint. All 3 are effective in delaying metastasis and overall survival in patients with non-metastatic castrate-resistant prostate cancer. So in my just final comments here, why is the devil's advocate wrong? So there's a 2-year average metastasis-free survival. And so in other words, if you use these drugs, you're going to delay the time to visible metastasis on a bone scan or a CAT scan by about 2 years. And the overall survival of these 3 agents has now been proven, and that was presented at ASCO. These novel hormonal therapy agents are generally well tolerated and do not, in general, deteriorate quality of life. You have to be mindful of the side effects, and you have to manage those side effects. These patients are in our urology practices. If you're just mindful and looking for them and empowering our staffs to look for them as well. I mean, look at all the patients in your practice who are on androgen deprivation therapy for non-metastatic disease, for biochemical recurrence, and keep a watch list on their PSA levels. There's generally good reimbursement from payers, and patients can stay with their urology provider longer. Look, I'm all about multidisciplinary care. I'm all about working as a team, and I work closely with my medical oncology partners, but even they would agree that when a patient has a good relationship, I can do an oral agent, maintain that patient in my practice. There's also a shortage of medical oncologists, and I want them to be available to treat some of the patients who are a little bit further advanced. And so I like to manage these non-metastatic patients, and my colleagues are happy to have me do that. Patients can avoid symptomatic chemotherapy, systemic chemotherapy longer. And as Dr. Karsh mentioned, we know that docetaxel is effective. We know that docetaxel has been a game changer in high volume metastatic disease. However, patients would like to avoid that in many cases, and I'm sure Dr. Yu will talk about that in a minute. And then there's certainly a robust effect on PSA. So again, I really want to thank everyone for joining tonight. And again, I want to particularly thank Dr. Karsh and Dr. Yu for being with us. And so now it gives me great pleasure to introduce again Dr. Evan Yu. Dr. Yu is broadcasting from the University of Washington, and I'll turn the podium over to you, sir.
All right, thanks so much for having me here tonight. So let me jump in and take over the slides. Let's see if this works now. Okay, there's my title slide here. Let's see if I have control now. Okay, it looks like I do. So here are my disclosures. And here are the discussion topics. So I'm going to talk about everything else, all the other fun stuff. So I'm going to talk about this term sequencing of agents. So that just basically means what to use in what order. And as you guys know, there's no definitive right or wrong, but there certainly are some pragmatic considerations, and there's some new data to help us kind of guide how we do things. Certainly more data than we had even a couple years ago. Combination therapy, I think what you just heard from the earlier couple talks is that treatment intensification earlier, which is essentially a combination, seems to lead to better outcomes, and these can be very dramatic outcomes. But since I'm focusing my talk mostly on metastatic castration-resistant prostate cancer, we'll talk about those outcomes with some of the combination trials, and if treatment intensification always leads to great outcomes, not always, okay? We'll talk about DNA repair deficiency, and it's also called homologous recombination deficiency, and there's new data with PARP inhibitors, perhaps with platinum chemotherapy, and the importance that Larry Karsh referred to earlier about genetic counseling, cascade downstream testing needs to be discussed as well. And we'll talk about immune oncology. Certainly our patients are all clamoring for the use of immunotherapies in this disease, and what's around the corner are theranostics or radioligand therapies, where we have a target and we're basically sending our radiotherapies directly to that target. So with that being said and done, I'll start with the first topic of sequencing. Many of you may have heard of this CARD trial. This was initially presented at ESMO, and this was a randomized controlled trial of pretty late line therapy. These were patients who had already received a novel hormonal therapy, either abiraterone or enzalutamide, and they'd also received docetaxel, and they had to have received at least 3 cycles of docetaxel to be eligible. So if you were like a rapid progressor through docetaxel, you didn't make it on the study. Additionally, with your first novel hormonal therapy that you received, whether that was abiraterone or enzalutamide, you had to progress in less than or equal to 12 months on that therapy. So if you look back at some of the pre-chemotherapy studies or even the post-chemotherapy studies, the median time till PSA progression is usually about a year on abiraterone or enzalutamide. It's a rough estimate. For radiographic progression, I rough estimate about a year and a half or so. So this basically allows the patients that are on the wrong side of the curve to be allowed on. So you can see more hormonally resistant, perhaps at least reasonably chemotherapy or docetaxel, taxane chemotherapy sensitive. And so that's how I think they were able to have only 255 patients randomized 1-to-1 to cabazitaxel plus prednisone, 25 milligrams per meter squared. That is the dose in Europe. And this trial was done essentially in Europe. In the United States, it's very common due to the Proselica trial for people to use 20 milligrams per meter squared, as that was found to be non-inferior to 25 milligrams per meter squared with less toxicity. But since it was done in Europe, they used 25 milligrams per meter squared, but they did mandate primary prophylaxis with G-CSF because the initial concerns with cabazitaxel were febrile neutropenia rates of 7.5% and toxic death rates of 4.9%. That's really been abrogated by the use of G-CSF or by the use of reduction to 20 milligrams per meter squared. Either way, that's how this trial was designed. And the control arm was either abiraterone or enzalutamide. So essentially, you would be randomized to the drug that you didn't receive the first time around. So if you'd received enzalutamide, you would get abiraterone. If you'd received abiraterone, you would get enzalutamide. The primary endpoint was radiographic progression-free survival, but certainly they had enough statistical power to look at key secondary endpoints like overall survival, other typical secondary endpoints as you can see here. So the demographics are interesting. Because of the way they set up their eligibility criteria, they had a very aggressive patient population. So rather than seeing most patients get onto the study by PSA progression, as we might see here in the United States, less than 10% of the patients made it on study by PSA progression. Almost about 2/3 or more than 2/3 of the patients made it on study by pain progression, which I would say is a pretty aggressive patient population. And if you look at the fact that the eligibility mandated that the novel hormonal therapy that they received first was only 12 months or less of treatment, the median, as you can see here, is around 8 months of duration. So a very aggressive biology patient population. They did have positive result for the primary analysis of radiographic progression-free survival. As you can see here, very statistically significant, nice p-value of cabazitaxel over switch to the other novel hormonal therapy agent. Radiographic progression-free survival from 3.7 months at median to 8 months at median. And they had a statistically significant overall survival result as well, with a median of 2.6 survival benefit there, as you can see. Now, when you look at the safety data, it's quite interesting. You know, not surprisingly, with the 25 milligrams per meter squared dose, there were patients who came off due to adverse events and leading to treatment discontinuation. And I think it's quite impressive to show the fact that 20% of the patients came off cabazitaxel due to the fact that they had some sort of adverse event leading to discontinuation, yet they still had such a dramatic overall survival benefit. Just goes to show how significant cabazitaxel is in this setting. certainly one has to admit the fact that they stacked the cards in their favor because this was a relatively taxane sensitive, hormonal resistant patient population. But that being said and done, for that third line therapy patient, cabazitaxel certainly a reasonable standard of care. And for those who have more aggressive biology and more hormonal resistance, I think it should be the standard of care. Now, we backtracked a little bit earlier, and I mentioned I was going to talk about combination therapies. And you can see that the theme here earlier, what Judd and what Larry talked about, is that treatment intensification leads to better outcomes. That hasn't necessarily panned out in recent trials for metastatic castration-resistant prostate cancer. So I'm not going to spend a lot of time on these, but this was an alliance trial saying, well, hey, if abiraterone is good and enzalutamide is good, let's put them both together in the MCRPC patient population and see if we can get better outcomes. And unfortunately, there was no improvement in outcomes of combining abiraterone with enzalutamide over enzalutamide alone as the control. What you did see is you saw more toxicity. You saw more fatigue with the combination, not surprising. You also saw more of the mineralocorticoid side effects of hypertension that one can get with abiraterone. So you get more toxicity, no efficacy benefit in this situation. Here's another example of another clinical trial where they thought, okay, we use radium-223 for those with bone metastases, metastatic castration-resistant prostate cancer, and symptoms. That's the FDA approval. However, what about using it for those maybe in an earlier disease state, symptoms not being a requirement in this trial, but either asymptomatic or mildly symptomatic, so going for an earlier disease state population and combining the radium-223 with abiraterone. So it was abiraterone plus placebo versus abiraterone plus radium-223. The primary objective in this trial was symptomatic skeletal events, but they certainly looked at overall survival as a secondary objective. As you can see with the curves here, neither was statistically significant in favor of the combination of abiraterone plus radium. If anything, the abiraterone plus placebo arm seemed to do better in regards to overall survival. Not statistically significantly better, but you can see numerically a little bit better. The one interesting thing is when you look at the fracture rates. The patients who got radium-223 in this study seemed to have more fractures. The good news is these were not pathologic fractures. They tended to be more osteoporotic fractures that were not at sites of metastases. And if you gave bone protective therapy like denosumab or zoledronic acid, that certainly made a difference and seemed to help. But bottom line is no benefit to adding radium to abiraterone there. So there's two studies there. Metastatic castration-resistant prostate cancer where more does not always equal to better. Now, I did throw in a case here, so I want to run through this real quick and kind of work through this because I think this is an important concept to think about. This is a 70-year-old gentleman diagnosed with new metastatic prostate cancer, has a prostate biopsy. This is a grade group 5 tumor. He has no family history of any cancers, but he has 2 living younger siblings, 3 healthy adult children with multiple grandchildren. So a lot of relatives. And he started on androgen deprivation therapy with abiraterone acetate. He asks you about genetic predisposition because he has all these grandchildren and he's concerned about the fact that he has prostate cancer at age 70, but is such a high grade prostate cancer, might he be at risk of passing on his cancer or his cancer genes to his offspring? So what's your answer here? So let's work through this. The options I put here are referral to a genetic counselor. That's 1. 2 is obtain germline testing from a salivary test cheek swab. 3 is to send prostate biopsy specimen for next generation sequencing. And 4 is to tell him there's no concern given his family history and age. Okay, so let's work through this. The first answer that I will remove from this list is I'll take away referral to a genetic counselor. Not that genetic counselors aren't great, but he has no family history of any cancers, okay? And we know that there's a national shortage of genetic counselors. This is becoming a very important issue, and we need to wisely know when to refer a patient to a genetic counselor. This patient, at this point in time, with the data that we have, does not warrant referral to a genetic counselor. Okay, what else would I not do here? I don't think that this patient, you're going to get the information that you want by sending his prostate biopsy specimen for next generation sequencing. I'm not saying it shouldn't be done. Certainly there are new actionable alterations to be thought about and looked at. But in this situation, that somatic testing is not going to give you germline predisposition. So that is not the right answer in this case to address this patient's concerns. The other answer that's not right is to tell him there's no concern given his family age and history. The studies show that certainly family history and age matter somewhat, but actually a recent study looked at patients with metastatic prostate cancer and found that there was a 12% risk of harboring germline DNA repair alterations, germline, inheritable, and there was not a great association with family history or with age. Now, it might have been select patient population, but it's not a definitive that a 70-year-old man does not have a germline predisposition, even if he has no family history here. So what I would do is the quick and easy dirty test, do a germline spit test or cheek swab. Color Genomics has one, Myriad has one. There's a lot of different ones that are not very expensive. We certainly have a clinical trial with the ability to do this for the patient. So why should we do this? Now, I mentioned again, on the left, you see that 12% risk of genetic germline alterations in 16 DNA repair genes that I mentioned. That's Colin Pritchard's data. On the right, that's the Stand Up to Cancer biopsy data from metastases. 23% risk of metastatic castration-resistant prostate cancers harboring DNA repair alterations. Now, why is there a difference? Well, on the left, these patients had metastatic disease regardless of castration sensitivity or castration resistance. On the right, they were all castration resistant, and the testing was done with whole exome or whole genome sequencing, actually. It was not intended to delineate whether it was germline or whether it was somatic. And a lot of patients, we were able, as part of the Stand Up to Cancer Dream Team, to determine that. However, it was not dedicated germline testing. So probably about half of these alterations were somatic and half were germline, leading us to about that number of around 12% or so. Why is this important? Well, let's say BRCA2. If you have BRCA2, you're going to do worse. You have a worse prognosis. And certainly we'll talk about therapy here because there's been data with PARP inhibitors that have shown great response rates. This looks at a randomized phase 3 trial, the PROfound trial of olaparib, a PARP inhibitor, versus enzalutamide or abiraterone. Similar to the CART design, these patients had a prior enza or abiraterone and were randomized to olaparib versus switch. And these were patients that had one of 16 DNA repair gene alterations. Cohort A was the primary cohort with radiographic progression-free survival as the primary endpoint. These were the patients with BRCA1, BRCA2, or ATM mutations. Cohort B were the other gene alterations, PALB2, RAD51, CHEK2, all these other gene alterations, and they did use Foundation Medicine for testing. As you can see here, very positive in cohort A, which was the primary endpoint cohort. Nice p-value there. Significant RPFS rate, almost doubled there between olaparib versus physician choice of switch to the other hormonal agent. Now, this is interesting because this looks at overall survival, and it's technically not statistically significant. If you look at cohort A, the p-value is 0.0173. The O'Brien-Fleming boundary was 0.01 at this interim analysis. We'll see with the final analysis, but it's not quite statistically significant, but almost there. And then they did this thing where they combined cohort A plus B. So remember, cohort B patients were patients who had other DNA repair gene alterations, some of which might respond better just as well, and some of which might not respond as well. You can see there that probably, if you look at these graphs, most of the benefit is derived from cohort A, the BRCA2, which is the most common alterations. But that being said and done, they did get an FDA approval across the board for all those different DNA repair alterations. The other PARP inhibitor I want to talk about here is the Triton-2 study with rucaparib. This is another PARP inhibitor. Open label phase 2 study led to an accelerated approval with 44% objective response rate in the BRCA1/2 population. Not as good in the ATM population, as you can see there as you look across CDK12, CHEK2. Not very many responders there. But based on all this data, it led to the FDA approval in prostate cancer. Based on the PROFOUND study, olaparib got approval in patients with pathogenic germline or somatic homologous recombination repair gene mutated metastatic castration-resistant prostate cancer who progressed following prior treatment with enzalutamide or abiraterone. So basically a pre-chemotherapy disease state. And there are the list of genes alterations. The other approval was for rucaparib. Based on the TRITON2 study, the FDA granted, this is an accelerated approval, not a full approval, to rucaparib for the treatment of patients with deleterious BRCA1, 2 germline and or somatic associated MCRPC, been treated with an androgen receptor directed targeted therapy, so abiraterone and enzalutamide, and a taxane-based chemotherapy. So the difference, rucaparib, BRCA1 or 2 only, and post-chemotherapy. Olaparib, broader label. Honestly, I like both drugs, but one is more precision medicine than the other. So precision medicine requires that you really have a label or you really have a biomarker that really helps predict response better. I'm not sure that all these lists of genes with olaparib predict response necessarily. That being said and done, there are some advantages to a looser label as well. And so the label is the label. These are things to be considered as you select PARP inhibitors for your patients who have DNA repair deficiency. Now, this is Heather Chang here, and she has the gentleman study, which I told you about. If you write down this website, you can go there, and any man with metastatic prostate cancer can log on to the website, take about 40 minutes of answering questions, and can get a color genomics test sent for free to them to basically do a spit test and get their sequencing results sent directly back to them. So that's nice. We recognize that essentially 1 to 2 2 men out of 10 will have a DNA repair alteration, for 1 probably germline and 1 somatic. And these patients might respond better to PARP inhibitors and or platinum. But one of them carries as an inherited DNA repair gene alteration, and that means there's a 50% chance that their offspring might have inherited that same DNA repair gene mutation as well. And so this is important, not just for prostate cancer and early screening effects there, but also for females with breast and ovarian cancer and screening effects there as well. So our group recognizes this, and we're working on efforts, since we work in prostate cancer, as part of our SPORE grant for screening at-risk mutation carriers, brothers and sons, and also working on neoadjuvant therapy for the patients who have germline alterations and high-risk localized prostate cancer. We're working on a concept through SWOG right now. So I want to move on to another topic, and that's topic of immunotherapy. The FDA did approve pembrolizumab in the first tissue site agnostic approval for microsatellite instability high and hypermutated solid tumors. This happened first in 2017. It was based on MSI high or mismatch repair deficient. That's MSH2, MLH1, MSH6, PMS1. These genes lead to microsatellite instability and hypermutation. But that hypermutation, tumor mutational burden high approval didn't come until June 2020. But this is tissue site agnostic. It can be a GI cancer, it can be breast cancer, it can be prostate cancer. So how often do we see this? One would think not so much, because prostate cancer is a mutationally low burden tumor compared to the carcinogen associated tumors like melanoma from UV light, or lung cancer, squamous, adeno from smoking, bladder cancer also from smoking. Those are higher mutational complexity cancers, more mutated proteins, more targets for your immune system to go after. But there are select patients with prostate cancer who do have this and have hypermutation and are likely to respond. In the Stand Up to Cancer metastatic biopsy series, it was about 3%. In our rapid tumor autopsy series, it was around 12% of patients. So real life is probably somewhere between 5 to 10%. Now, what about for unselected patient populations that don't have a genetic predisposition? Well, Julie Graff did great work by adding pembrolizumab to enzalutamide progressors. And she saw about 19% of patients with a dramatic PSA response rate. You can see these PSAs here. It's not like 70 to 65 here, it's 70 to undetectable basically, 2,500 to undetectable. These are very dramatic responders. So this led to some randomized controlled trial development with pembrolizumab. Recently, unfortunately, with the atezolizumab in the Ambassador 250 trial, this was added to pembrolizumab with MCRPC. And this was closed for futility at the interim analysis. Chris Sweeney did present the data at AACR this year. There are patient groups that we might enrich for mismatch repair alterations and DNA repair alterations, however. The ductal histology does really poorly. This is a poor prognostic risk group. So Mike Schweitzer at our center looked at it with our pathologist, said, this kind of looks like colon cancer cribiforming under the microscope, and found that in the first 10 patients or so, 40% had mismatch repair alterations and had some nice anecdotes of patients responding to pembrolizumab immunotherapy. But as we expanded the study and added Hopkins and Calgary as collaborators, we found there were just as many patients with DNA repair gene alterations. But when you added it all together, almost about half the patients had some sort of actionable alteration. All right. Now the field is excited about unenriched populations. Can we go for unselected patient populations and still find responses? Well, with PARP inhibitors in the TOPARP studies, it was about a 6% response rate. With pembrolizumab in prostate cancer studies by itself, it was about a 5 to 10% response rate. Here's combination with pembrolizumab and olaparib PARP inhibitors, Keynote trials 365, as you can see to the right. And what we're seeing is interesting, is it's over a 20% response rate there in soft tissue patients specifically. So the challenge that we have is we're not sure we get the same results in bone metastases, but this might be an interesting niche, and there's a randomized phase 3 trial ongoing with that combination. I do want to wrap up with what's coming around the corner. Okay, what else is coming? And that's the fact that there are radio ligand therapies or theragnostics. You've heard of lutetium, PSMA 617. Lutetium 177 is a beta emitting radiopharmaceutical. PSMA, highly expressed on prostate cancer. 617 is a small molecule that binds to it. On the randomized phase 3 VISION trial, you had to get a gallium PSMA PET scan. You had to have received prior taxane chemotherapy, and then you're randomized to lutetium 617 versus best supportive standard of care. And that data we're waiting to see, but you can see on the left there that there's early phase 2 data that looks pretty promising, certainly in regards to PSA response and in regards to soft tissue resist responses in a small patient population. So we're excited to see the results of this study coming down the road as well. So I just want to wrap up with key take-home points. For patients with a short-lived response to novel hormonal agents, chemotherapy to cabazitaxel is superior to use of another novel hormonal agent. Probably best for those who had very short limited responses to the first novel hormonal therapy agent. Treatment intensification in metastatic castration-resistant prostate cancer has not duplicated the types of results we've seen in castration-sensitive prostate cancer. DNA repair gene alterations in 23% of MCRPC patients, 12% germline in all metastatic prostate cancer patients. Seriously consider offering germline testing for all patients with metastatic prostate cancer. Olaparib and rucaparib, PARP inhibitors have regulatory approval for select DNA repair gene alterations. Pembrolizumab, FDA approval, tissue agnostic for MSI high or hypermutated prostate cancer. And theranostics with lutetium 617 are being tested right now and might be around the corner. Thanks so much.
Thanks, Evan, and thanks, Larry, for both fantastic talks. I just want to make a comment to the audience that I've been fortunate to be part of this course now for I think the last 7 years at the AUA, and Dr. Karsh and I have worked together. We're really excited to have. We were able to entice Dr. Yu to join us this year, and he did a great job. But it's amazing how things have changed over the last 7 years. I can't even imagine some of the things that both Larry and Evan talked about today that we would have been talking about 7 years ago. So for the residents and the students and the young folks listening in, it's hard for you guys to imagine, but this has been an amazing time in advanced prostate cancer and will continue to change as molecular medicine and precision medicine changes. And now we just have a few minutes for questions, and I'm going to get right into this. This is a really good question. And I'm going to just ask both Dr. Karsh and Dr. Yu to comment. Someone wrote in, congratulations, great course. And they're asking about the incidence of fractures in the PROSPER trial. And they said it was 18%, and there was only a baseline use of bone targeting agents in 11%. It's not published in Spartan. the question is, why is there such a low use of bone protection agents in these patients who were, I guess, enrolled in Spartan or in in Prosper? And maybe I'll just start with Larry. Obviously, you have a very busy practice. Can you want to just comment on bone targeted agents? I guess that would be an M0 CRPC.
No, I think that's a great question, and it's a question I've been asking. How come in those trials there was such a low incidence? I think it was somewhere between 10 and 15% in each of those studies of patients being on bone-targeted therapies. And I think we need to pay attention to that much more. I think at our institution, what we do is the minute patients get on ADT, we start them on vitamin D, calcium, have them get an exercise program, and we will get a DEXA scan. Usually we have to wait about a month until they're castrate, but we haven't had much of a problem getting it approved. And we get the baseline and then we watch it, and we'll treat those patients with low-dose denosumab or a bisphosphonate if they have low density. But I think that's an important point, and it doesn't get addressed out there.
Evan, do you want to comment from also?
Yeah, I don't have a lot to add. I have a similar experience. I think the issue is we know that androgen deprivation therapy alone leads to increased loss of bone mineral density and increased risk of osteoporotic fractures. So now we're treatment intensifying. So if we're not giving them calcium, vitamin D, having them exercise, do some resistance training, and thinking about other risk factors and getting DEXA scans to risk stratify, then we're not doing a proper service for our patients. So we got to think about it.
Just a practical, what I do, and this is for some of the other urologists, I'm fortunate that I have a longtime physician's assistant who is my teammate, and we've basically been working off and on for about 20 years. And so he's my bone health champion in practice. And so whenever I have a new start on ADT in Epic, I include him on the chart and make sure that he peer reviews me, quite frankly, because, we're busy and I sometimes forget. And so at least having another person to check and the vitamin D and calcium, he makes sure the patient gets a handout. And just one comment, maybe just to follow up with Larry, that so you did mention the low dose denosumab, and just from an educational teaching standpoint, maybe just give the audience the difference. When would you use the low dose denosumab versus the higher dose?
So the low dose was approved to prevent fractures in men on ADT, and the low dose would be 60 milligrams every 6 months. High dose is for prevention of skeletal related events in men with bone mets. And that's a high dose. It's indicated every month. But the longer that they're on these therapies, like the high dose, the higher the risk of ONJ, osteonecrosis of the jaw, increases. So we've been putting patients on for about a year monthly, and then moving on to 3 months. Now that's not in the label. But I think the longer they have exposure to this, you see more ONJ, and we do see ONJ out there. I mean, it's a low percentage in the trials with the Amgen 103. I think it was somewhere around 2% at 2 years, and it went up a percent for each year that they were on. But I see it out there.
So I think we are just about out of time, but I just do want to end with a question for Dr. Yu. I think a lot of urologists, including myself, our heads are spinning a little bit with the precision medicine and all the cabs, could you just maybe give a what's the bottom line key teaching point that a community urologist needs to know about the molecular genetics of a patient with metastatic prostate cancer? I know that's a hard, I'm putting you to work.
I mean, there's no way to summarize it. The easiest way to summarize it is if you're gonna do this, you better learn it. I'm a straight shooter. So if you're not willing to take take time to learn the biology and learn how the drugs work and learn the potential toxicities, don't give it. But if you are, I'm not one of those medical oncologists that says I have to own all advanced prostate cancer. I don't care who does it as long as you know how to do a good job. So what I'm saying is that I have no problem with you guys using immunotherapy, PARP inhibitors, whatever, but learn the biology, learn how to give it, learn the potential toxicities. And if you don't, there's no harm. I don't do everything. I don't operate on the prostate. So, then we share patients and we work well together. So that'd be my summary.
That's a beautiful ending. So again, I just want to thank all the attendees. I know we had a fantastic audience tonight. I know there were hundreds of people registered for this. This is going to be also a durable continuing activity that's been recorded. I do want to thank Dr. Yu and Dr. Karsh very much. I really wish we were together in person. This is getting old. I love these. I love webinars, but this is getting old. I'm looking forward to being back at AUA and ASCO in 2021, and I'm sure a lot of people are. So we will close this session. Thank you guys very much, and see everybody at AUA 21.
Thanks.
Thank you.
Thank you. Thank you, John and Evan.